Hi everyone, my name is Yi. I'm your host for Occupational Medicine Pearls podcast. In this episode, I would like to cover tuberculosis in occupational medicine context in Australia. Tuberculosis is relevant in occupational sense for the purpose of the assessing for occupational physician. They are under the domain 20, which is about biological agent, and also under domain 10, which is about managing infectious agent or respiratory conditions. It is also crossing in domain 60, which is population health approach. So let's start. Australia is a low incidence country, which is not surprising since mid 80s, and we have about 5 to 7 notification per 100,000 per year. That's quite few. And the defining feature is overseas-born population accounts for 92% of cases, with highest case numbers from the Philippines, India, Nepal, and Vietnam. Australian-born non-indigenous rate is about 0.7 per 100,000. So it is quite low. Aboriginal and Torres Strait Islander people carry a disproportionately higher rate, unfortunately, and MDR TB or multi-drug resistant TB remain low, which is really good to hear. And Australia removed BCG vaccination from National Immunization Program in the 80s, and it is only used in targeted settings these days. The low incidence point is important because when we are screening for people, we want to screen only for targeted population. If we screen for every single person, that may generate mostly false positive result, and in low population sense there is also low positive predicted value, so it doesn't really make sense. Let's talk about the bacteria first. Tuberculosis is caused by a mycobacterium species. There are many of them, but for our context, we need to know, or we must know, Mycobacterium tuberculosis complex. It is an acid-fast bacilli. It doesn't react with the acid staining, slow-growing, and aerobic. It can survive intracellularly in macrophages, and it causes granuloma formation and the need for prolonged period of antibiotics treatment. Transmission is from airborne droplet spread from person to person. However, it is not something you can get from a single meeting. We need close proximity, long duration, and poorly ventilated space to transmit to tuberculosis. That's talking about pulmonary TB. Extrapulmonary TB, like skin, are even less infectious. Sometimes the transmission itself is due to immune factor due to the host, such as young age or poor immune compromise, poor immune status, and if people have nutritional problems, they are the host factors. Natural history is that people may get exposure to it and may clear, or otherwise they continue on into either active disease or latent TB infection. Active disease is simple. There will be chronic cough 2 to 3 weeks, fever, night sweats, weight loss, and hemoptysis can happen, and they could be infectious to other people from their pulmonary and laryngeal secretion. When you do chest X-ray, there will be abnormal finding on the apical part of the X-ray, and also sputum AFB testing will also be positive. Contrast to that, latent TB infection is that people do not develop symptom. They're asymptomatic, they are not infectious, and they may have normal X-ray sputum negative. However, when you do test the mental test or the quantiferon gold test, they will be positive. There is about 5 to 10% lifetime risk of reactivation in immunocompetent people and higher in people with poor immunity. So when people get older, that could become an issue. So the distinction point is that if you found someone with positive tests on the screening, it doesn't mean may not mean they have active tuberculosis infection. They may not be infectious, and that is important point for fitness for duty work. Occupational group at risk: healthcare workers, especially working in the respiratory emergency ICU aged care, who may be exposed to people with infection or the people are coughing. I would also add aid workers or people who are assisting with the recently arrived refugees. They would be higher risk of exposure. laboratory staff culturing and assessing the sputum sample, aged care, a correctional facility, homeless shelter, drug and alcohol services, and immigration detention center workers. And not just workers, healthcare workers who are working in these facilities may also be higher risk. People who are traveling for work to the endemic area that include many parts of Asia, Africa, and interestingly, silica-exposed workers, that is unique to silica. Silicosis substantially increased tuberculosis risk, and that's important to know. Abattoir workers or veterinary, and they may be for Mycobacterium bovis, but it's very rare in Australia. I mentioned two tests before. The first one is tuberculin skin test or MEN2 test. It is testing for type 4 hypersensitivity. What we do is that we inject the liquid to enter the skin intradermally and read in 2 days and day 5 or day 4. And we are looking at the skin changes on that. If there is red, raised, or itchy area, that would be regarded as a positive. Obviously, false positive could happen from prior BCG vaccination or other type of mycobacteria. False negative may happen in immunosuppression or if they had recent infection and they are in the window period or when they have miliary TB or overwhelming disease. Then in terms of doing that, you do the skin test on the day one and then second visit you check the skin. The second test is that a lot simpler is blood test, quantiferon gold or interferon gamma release assay IGRA, a single blood test, and it is not the same. It is not confounded by BCGs. People who had BCG vaccine should not be positive on that. One visit, and there is no subjectivity due to the reader. And it is preferred now these days to do the occupational and migrant screening. However, neither the skin test or the quantiferon gold test can distinguish latent TB from active disease, and both only detect previous infection and sensitization. For that, to know that, we need to include clinical history and other tests like chest X-ray or sputum assessment if they can produce them. So chest X-ray screen for active pulmonary disease, and we are looking at apical envelope changes, cavitation, and fibronodular scarring. We can also perform sputum for SFS bacilli, and they are a lot more fastidious. So people who are taking antibiotics for other reason may be falsely negative. So it's important to get a good history of treatment or incomplete treatments. Let's say we get the result. How do we do that? We have positive blood tests or skin tests in an asymptomatic worker and normal X-ray, and we have to regard that as a latent tuberculosis. So they are infected but not infective, and whether they can be fit for that role depends on the context. If we have positive tests and symptoms or abnormal chest X-ray, then we have trouble. We have someone with active tuberculosis, so urgent referral is needed, sputum, respiratory isolation. Or if there are conversion, and if we are following someone, if they are changing from negative to positive tests, then they would get exposure recently. If they have a travel history to high-risk area, that may make sense. But if they haven't had any travel, public health need to start looking for source investigation. It is where our role probably stopped. We need to interpret the result and need to hand over properly to the appropriate authorities to do further workup, but we don't get involved beyond that point. Coming back to occupational health context, when we are doing screening, we would screen at pre-placement as a baseline. We should also do periodic surveillance. Some work occupational settings require annual health checkup and need to check yearly. If tuberculosis as an occupational airborne hazard, that's something we need to understand overall, but it follows the general air quality or environmental ventilation assessment. So elimination is that we need to identify people with active infection and treat them adequately and isolate them. Engineering is for each room need to have good ventilation, and also for the treatment in the hospital, there should be isolation room, negative pressure, and the adequate air change per hour, airflow per hour. The air filtration system should have the HEPA filtration. UV germicidal irradiation can also be used as well. Administratively, is triaging the identification and having suspicion about tuberculosis in people with suspected history. And we are talking more about people coming from the high risk area or people who could be positive with infection. PPE is the fit testing, N95 is important, or P2 mask for respiratory protection. So, fitness for work, if they have latent tuberculosis, they are fit to work. They are not infectious. Should not be no work restriction. And preventive treatment is a clinical decision that the worker can discuss with their treating practitioner, but that should not be a fitness barrier. Obviously, if they have active tuberculosis infection with symptom, they need to take time off to receive treatment with the proper treatment. And when they are finishing treatment, they need to demonstrate that they are no longer infectious. That depends on treating specialists or clinicians' report on that. Not only that, anti-tuberculosis or anti-TB drugs can have hepatotoxicity, peripheral neuropathy, hearing impairment, and visual changes, orange discoloration of the teeth and the urine. So it is important to understand that what sort of side effects that the worker may experience and need to assess if they have these symptoms. So if they need to work at heights and need to make sure they do not have peripheral neuropathy, they are not having ENT related symptoms. Tuberculosis is a notifiable disease and also important if someone got tuberculosis through work, that is also notifiable to regulator. All right, that's all I have to mention about tuberculosis. I hope you find this episode useful. I will see you next time.